Hello, hello,
Hi,
everybody. Oh, hey, how are you?
I'm doing well. How are you?
Good, good, good to see you.
Yeah, likewise. I know I haven't made it to AES last 2 years. Hopefully this year.
Yes, yes, yeah, we missed you. Yeah, yeah, you look great. And
Oh, thank you.
yeah,
Yeah.
how's New Mexico? Looks nice and sunny out there.
Yeah, it looks nice. It's like 100 degrees, like it's been like last 2, 3 days, so it's super hot.
Oh,
But it's okay. I'm always indoors anyway, so
well, it's a beautiful, yeah, I mean, it's a beautiful state. It's
yeah,
just gorgeous.
definitely. Yes.
Wow. Yeah. So, are you enjoying life there?
Yeah, yeah, it's like, it's kind of this is like beginning of the academic year. We have like new residents, so it's been kind of whirlwind. I'm leaving for vacation next week, so I have like all these things I need to finish.
Oh,
So, but yeah, it's good. It's we have great team. So
that's
we
wonderful.
actually just like we didn't have lit yet, so I heard that it's gonna get approved, so that's exciting. We'll see.
Okay, fantastic. Yeah. Well, thanks so much for joining us and agreeing to give this lecture. I'm really excited to hear this. We haven't had anything like this topic, so this is
Yeah,
wonderful.
also, yeah, great. Yeah, I'm glad I could make it today. Yeah, thanks for inviting.
Yeah, thank you. Hi, Camilo. How are you?
Good. How are
So,
you?
good, good. So, normally we have a co-host, Dr. Hop, Jenny Hop at Maryland. Unfortunately, she's not able to make it this week, so sorry about that, due to another commitment. And Dr. Steinman is another co-host, and she's I think on at this point too. So we'll just wait. Usually, there's a few more logins, so we'll wait a little bit more. Um, Unfortunately, some people from our group will not be able to make it. Scott is actually on vacation, so sorry. And it sounds like Chris is is covering resident clinic today, so sorry. They apologize for not being here. Um, let's see. So we'll wait till probably 5 after, and then we can start with the introductions and everything. Okay?
Okay, sounds good. I think that's kind of the norm anyway, like,
Yeah,
start fast. Yeah.
yeah, yeah. That's great. Yeah. Okay, let's see. So good. See more people are continue still. And another thing, this year we are also, I'm not sure if they got the invites for this meeting, but we have expanded the group. So we are now, Cornell is actually joining our group. So we'll have more participants and more lecturers. So it should be even better the year going forward for everybody. And actually, so many of you may be, or some of you may be new to this program. This is, of course, for epilepsy fellows and faculty at the member institutions. And it is a lecture series that we have every month where we cover different topics. It can range from basic kind of mainly educational kind of program for the fellow education, as well as research topics and cutting edge, up to date information clinically. It really, there's quite a variety, and it depends upon the speakers, what their interests are and expertise is. So today we have a really exciting speaker and who has a very, really wonderful lecture topic that I'm looking forward to. Let's see. So just one more minute and then we'll start, okay? See, just bring up this one document here. Oh, one thing, so sorry about this for everybody. Today, there is no CME for this lecture because there's some sort of delay within the Jefferson CME. So I'm so sorry, but we don't have a code for today, just so that you know. But from next month, there should be, okay? All right, so I guess we'll go ahead and start. It's my pleasure to introduce today's speaker, Dr. Bhat, who was one of our epilepsy fellows here at Jefferson. So it's really just fantastic to see her again and to see her in this capacity. She is currently an associate professor of neurology at the University of New Mexico. She received her MBBS degree from Mysore Medical College in India, and then her PhD from the University of Zurich in Switzerland. Then she completed her neurology residency at UMDNJ Rutgers, and followed by her epilepsy and clinical neurophysiology fellowships here at Jefferson. Her main interests are in epilepsy, pregnancy and epilepsy, and in ethics in epilepsy, as well as epilepsy surgery. She also serves as the neurology residency program director at University of New Mexico, and she'll be talking to us about ethics in epilepsy. So again, thank you so much for coming.
Yeah, thanks for the invite. Let me share my screen. Hopefully it works. I always have trouble finding the button. Okay. So, okay, where did it go now? Okay. Okay, can you all see my
Yes.
screen now? Perfect.
Yes.
Okay. All right. Yeah, thanks for inviting me, Dr. Nay. I know I have like really fond memories of Jefferson, and I even tell my residents, hey, apply to residency there. It's great. Like if they are interested in going to the med students and like, oh, you should apply for fellowship there. So really like one of the best 2 years of my life. So thank you for that. And then so after that, I moved to New Mexico. So I had very different kind of, transition. So like living from a city to like a suburb. And also kind of just the patient population was very different here. It's a very rural state, very underserved. UNM is kind of the only academic center and also the only level 4 epilepsy center, and actually the only EMU even in the whole state. So just kind of coming here, like working here, I like realized a lot of things which I had not thought about or, did not think about living in the East Coast in like urban areas. So there are some problems specific to like rural and underserved areas that I kind of explored here, and that made me more interested in like exploring this topic. And this was one of I worked on grand rounds from with one of our fellows on this as well. So I don't have any disclosures. And also, I'm not any sort of expert in any way. I don't have any degree in philosophy or ethics. So a lot of this is kind of my own interest and what I have read and kind of working with the patients with the challenges and the opportunities I had here. So again, feel free to speak up. It's, I don't mind getting interrupted. So if you have any questions, feel free to ask me. Don't have to wait till the end. So kind of these are our learning objectives to identify, what are the ethical issues that arise during the care of patients with epilepsy. We'll review the laws and kind of compare the laws that affect the lives and care of patients with epilepsy. Propose some changes to policy and practice so that there is equitable care for patients with epilepsy. And also think about a little bit of what ethical considerations we should keep in mind when we are discussing epilepsy surgery and neuromodulation with the patients. So, okay, I have a fun question. So if you guys want to indulge me, let me see if this works here. Okay. So if you want to join in Slido, this is the code. So let's say you're undergoing an elective surgery and you just overhear that the surgeon has epilepsy. So how long would they need to be seizure free for you, just you, to feel comfortable with them operating on you? So if you guys want to take a few seconds to answer this question, can you see my screen?
Yeah, do you want us to answer in the chat or verbally?
You can do, or you can, John, if you just go to slido.com, put this code, this number, it will actually let you answer, like put in the number there, so you can do that as well.
I don't know, when I go to it, it says voting closed.
Oh, really? Huh, that's weird. I don't know why it says that. Let me see. Yeah, that's interesting. Sorry, I'm kind of technologically challenged sometimes. So is it, maybe I kind of ended it in a weird way? Yeah, I don't know why it says that voting closed. Oh, sorry about that. Okay, so if you guys would just want to use the chat function, let me see if the next one comes. Oh, okay. All right. So I don't know. This one didn't work. The next one will work probably. So if you guys want to just use the chat function, okay. 6 months, okay. 1 year, all right. Any other answers? 6 months, okay. If you say 2 years, I don't think again, it's individual preference, not any like law or anything. Okay. All right. Okay. So looks like it's somewhere between 6 months to 1 year. Okay. Thank you for that. So when we think about medical ethics, there are kind of four pillars, like four what I would say concepts. So one is, kind of beneficence, meaning we want to act in the best interest of our patient. But also another one is non-maleficence, meaning we don't want to cause any harm to the patient. And again, those are two very different things. And then there is also justice and autonomy, which means justice means we want to emphasize quality and distribution of resources amongst all individuals, while also respecting their autonomy to make their own decisions. So a lot of times what we encounter is kind of this um, conflict between either the beneficence, non-maleficence, or justice and autonomy, because these are not, sometimes they overlap. So this is what I want to kind of discuss today. So the first thing we always come across is driving, right? Like this is kind of a big restriction for a lot of patients with epilepsy. So federally, if we look at the law, so Department of Transportation requires commercial drivers to be seizure-free off anti-seizure medication for 10 years before getting a CDL. FAA has really strict laws as well. So pilots and air traffic controllers need to be seizure-free for 10 years and off medication for 3 years before being eligible for license. And just even if they fulfill this criteria, they still need to undergo extensive workup. They need like long-term EEG, MRI, medical exam, etc. So there is like no real guarantee. So most of our patients probably won't get any of these jobs, but because, it's really rare and hard to achieve this kind of level of seizure freedom and being off seizure medications. When it comes to the state laws are very variable. So most states requires anywhere from 3 to 12 months. Some states actually there is no, like Wyoming, like there is no set period. So it's depends on the DMV. Most states is 3 to 6 months. Some states is 12 months. New Mexico is 6 months, and I know same is Pennsylvania. And Pennsylvania is one of the mandatory reporting states, along with California, Delaware, Nevada, New Jersey, Oregon. And I'm sure um, practicing there, all of you will have your own kind of, nuances, how you deal with it or how you talk to the patients. So what are the favorable factors that affect seizure-free intervals? So again, if somebody has a seizure during a practitioner-directed medication changes, the chance of them doing well is pretty good. If they have focus seizure without impaired awareness, that does not interfere with motor control. If they have an established pattern of seizures occurring exclusively during sleep, like nocturnal seizures, or seizures that occur secondary to definitive provoking factors that are unlikely to recur. Maybe they just had one, one incidence where I had a few patients who actually were doing well, and then they had COVID, and then they had seizures, and they all went on being seizure free after that acute illness passed. So these are the patients who probably will do well. But there are a lot of other factors that are actually unfavorable and affect the seizure-free intervals. So anybody who has a documented non-adherence to medication or even like medical visits, if they have any use of substance use disorder, if they had prior crashes due to seizures, prior record of MVA or violations of driving regulations. But again, this is very specific. Not all of this record is available to public. If they had increased number of seizures in the recent past from baseline, if they have been refractory to multiple anti-seizure medications, and they start having seizures after being seizure-free, and they having seizures that actually they're unaware of, which can happen very frequently in our patient population, or if they have like a structural brain lesion or like some disease that will actually worsen over time, like a degenerative disease or malignancy. So these are the studies that looked at the risk of seizure recurrence over 12 months following seizure-free interval of varying duration. So for not remote symptomatic, six month seizure freedom percentage was 15%. For remote symptomatic, it was 20%. This is, I think, pretty much what we would expect. And 12 months was 8% and 13%, and 18 months was 11% and 9%. So, and also they also looked at odds ratio for motor vehicle accidents after being seizure-free interval of varying duration. So because most of the state law is either 3 months, 6 months, or 12 months. So for 3 months, the odds ratio was about 0.4, 6 months was 0.147, and more than 12 months was 0.075. So when we consider the risk, there is a modest but increased risk of motor vehicle accidents with epileptic seizures. And then increased seizure frequencies are associated with high risk of motor vehicle accidents. But however, like if we compare other factors that actually can cause a motor vehicle accident, such as alcohol use disorder or like young teenage drivers between the age of 16 to 19, so the risk is not really high. Based on what I read, for epileptic seizure, the hazards ratio is about 1.3, whereas for the teen drivers is about 1.5, and for alcohol is, depending on the studies, anywhere from 1.75 to 2. So there is, again, although there is a risk, it's actually not higher than other factors that can actually cause an accident. And then for, again, the longer they go, there is a decline in the seizure, longer seizure-free interval, there is a decline in this number of accidents. So universal, again, at population level, a lot of time, there is a legal requirement of at least 3 months. But anything more than 3 months, actually, there is not, again, significant reduction in risk of accidents. Again, this has to be taken on an individual basis. And working in New Mexico, I have encountered things that I had not seen living in, in big cities, because a lot of times actually patients would not tell people, like their doctors, they are driving, or they even actually disregard legal restrictions if there are like really very onerous seizure-free intervals. In Maryland, actually, and also in Arizona was done way before in 1990s. Recently, in 2003, actually, Maryland, they recommended minimum of 3 months seizure-free interval. And then they actually saw only 2 accidents over the next 7 years. Same was in Arizona, but that was like a really older study from 1990s. But we have to remember, driving is actually really important for quality of life, for supporting social and work-related activities. And for a lot of people, it's like their life revolves around driving. And also, please feel free to correct me. I do not work in a mandatory reporting state, but the surveys and the data show that actually mandatory reporting actually does not decrease. Actually, it makes people actually withhold the information from their physician or from their team. So it's actually more harmful than useful. So the AEN, along with American Epilepsy Society and Epilepsy Foundation of America, they came up with this the statement that was just released in March of 2025. I'm not going to go over everything, but this is kind of the summary of the recommendations. So probably seizure-free interval of 3 months for most people is sufficient. And the medical advisory board should allow for input from physicians and customized for patients. If was a seizure that occurred exclusively from a provoking factor, and it's unlikely to recur, then probably there should not be any waiting period. And we should be able to report to the driving authorities as physicians or as treating clinicians, but not mandated. And we should be immune to prosecution either way, because there were some cases where there was like a lawsuit against the physician because uh, the patient had a seizure when the medications were changed and things like that. And again, we should remember that, medication can cause impairment. And the government, again, should obviously, this is kind of, of vision that there should be a robust public system to alleviate burden of not being able to drive. So this is the next question. Hopefully this works. Let's see. So let's say you couldn't drive, like for some reason I couldn't drive from tomorrow. How much money would you have to pay somebody not to drive car for 1 year? Like any number, is it $100, $20,000, $50,000? So hopefully this works. Let me know if it says active poll. So hopefully all of you will be able to join and put in a number. Is it working? No, don't know. 4,000, okay, awesome, okay. 80,000, okay. 5,000. Okay. 10,000, okay. Okay, all right. So the actual number is quite different. So let me go back to my slides. Okay. So on an average, actually, again, this one is considering average, like not city versus rural area. So people would pay somewhere close to like $12,000 to not to have access to their privately owned vehicles. And obviously during COVID, this value increased way higher because people were like really isolated. And then rural and suburban people value their car access more on average. And I can say that for sure, because like when I lived in Philadelphia, I lived like, 2 blocks from the hospital. I didn't even have a car, but coming to rural New Mexico, I definitely need to have a car. So again, the car access is more valuable in rural and suburban areas. So I kind of took a screenshot just to see how much, let's say from tomorrow, I couldn't drive, something happened and I couldn't drive my car, how long it would take me to reach work. So I looked it for a Tuesday morning because I have clinic from 9 o'clock, right? So I need to be there by 9. So if I drive, I live kind of like all the way close to the mountains. I need to take this highway, I-25. So usually if I drive, it takes me anywhere from 18 to 20 minutes. And I live in Albuquerque, which is fairly urban, I would say. It's a medium-sized metro, which decent public transportation. Even if I had to take a public transportation, it would take me 1 hour and 6 minutes, and I would have to walk in between to catch a bus and then a train. So it would take me up close to 1 hour and 6 minutes. And on top of it, if I had to drop off my kid to school and then make it to work, I would probably have to, consider that time as well. So even in like people who live in semi-urban or urban areas, driving is actually really essential. And actually, it's even financially worth it because there are studies that looked at the income. So the household without cars, they have been getting poorer over time. So the median income for a household without a car, again, this is a study from 2013, was about 17,000 in 2013 versus 1969 was 26,000. And households with cars have been getting wealthier. And this was the median income for households with car. In 1969 was 54,000 and in 2013 was 62,000. So again, like having a car, being able to drive is actually financially meaningful to people. And if you consider rural US, where there is no public transportation, no even, even maybe the roads are also not great. Like if you have a bike or even if you to ride something which is not a car, maybe there is not enough access for that. Even it's actually they get hurt the most. Rural carless households earn 64% less than those with cars. Rural carless households earn 40% less than non-rural households without cars. So even between rural and non-rural household who do not have a car, the rural households earn less actually. And also rural people actually do not use other modes of transportation like, walking, biking, or public transportation as much as their non-rural peers, which is 38.9 versus 74.6%. So again, like these are all kind of the things we want to remember, that although, there is a risk of accidents and everything, we have to consider these laws that apply to people. Again, we're not going to be able to change all these laws in this one lecture, but kind of things to think about. And the next section, we will talk a little bit about how we think about ethics in epilepsy surgery and neuromodulation. Because this is a very kind of topic that I've encountered here actually a lot. Um, when I was in Philadelphia and I was a fellow, we did like so many epilepsy surgeries. Then I came here, and it was kind of a big change for me because um, people did not want any surgery. They did not want anything to do with surgery. As soon as I mentioned anything like remotely, can we think about surgery? People were like really, were like skeptical, like, why am I recommending this? Like, what am I going to benefit from? So really had to work a lot to understand people, build a rapport with patients, and kind of discuss these over time to actually for them to agree for epilepsy surgery, even workup. So there are a lot of things. So again, like this is our kind of the 4 pillar. So if we what factors affect into different aspects of care in epilepsy. So just the epilepsy treatment, again, just access to surgical epilepsy center is actually there is poor access in the whole of US. People get, I think the wait time to get referred to an epilepsy center for epilepsy surgery workup was like 20 years or so recently. So again, people don't even get referred to an epilepsy center. So I think there is a lot of, poor access when it comes to sophisticated epilepsy treatment options. And also, there are a lot of barriers to surgical treatment that we want to think about. I think one of the studies looked that people with epilepsy were 8 times higher to have other comorbidities, whatever it was, diabetes, obstructive sleep apnea, or hypertension, compared to non healthy controls who had other chronic conditions. So again, we want to think about those as well. And I think also cultural considerations we need to think about, because where I live, there is the state has about 11 to 15% Native Americans, and also it's a minority majority state. So 55% of the patient is also Hispanic. So culturally, it's really hard to sometimes communicate what we want to, what our recommendation is. There's also a language barrier a lot of times that we have to overcome. And then when we think about what, the epilepsy surgery treatment itself, so also we have to consider what is the decision-making capacity for these patients. Are they really understanding what I'm trying to say? It was actually the reading, like health literacy level for UNM and all the patient education materials had to be at a 3rd grade reading level. I'm not sure what it is other places, but that also tells you that we have to actually really simplify a lot of what we are saying to the patients. And also, again, getting an informed consent is also really important, because sometimes, again, people might say yes, yes to everything we are saying, but we have to make sure that they actually really understand. And also in surgical epilepsy, we have to remember if we are recommending, stereo EEG followed by maybe, if they have a stereo EEG, maybe they need to actually get a grid after that because don't really have a good seizure localization or seizure onset zone, followed by maybe extensive resection versus recommending something else like a DBS or a VNS. So there also we have to think about beneficence versus non-maleficence, because what am I recommending is actually the most beneficial for the patient and also not causing the harm. And another thing which was like very unique is like kind of access to care and resource allocation. And as I said, like um, coming here, people actually don't even have access to like running water or internet, which I took for granted living in urban areas. So actually we had few patients who were actually had RNS placed, but they did not have any internet connection. They did not have, secure internet, and they lived in the reservation. So it was really hard to make a plan for them to go to maybe a public library or um, somewhere where they could download their RNS data. And sometimes people had to travel. Unfortunately, I have patients who come from, like far away, like 200, 300 miles away for one visit. So we have to also kind of consider all of those when we are recommending this treatment. And also when it comes to neuromodulation, um, we have to remember like autonomy, privacy, confidentiality, because a lot of this information is, although it's safe, it's in a cloud. So who has access to these? Who is able to access? How we're going to monitor that? And sometimes the patients will ask you, what happens to this information? Who has access to my, my brain waves? Who is able to look at this testing that I'm undergoing? So I think we have to remember those also when it comes to neuromodulation and devices. So this is kind of the workflow that has been recommended for informed consent. So first of all, we had to determine if the patient has a decision-making capacity. If they don't, but again, some patients may be able to make some decisions, but definitely need help with some of the other decisions. So we had to, obviously get our the neurocognitive colleagues involved and kind of determine that. So people with epilepsy or proxies must be given enough information to make an informed decision regarding treatment. So it has to be conveyed in a comprehensive uh, and also comprehensible manner. I really had to let go of some of the medical jargon. So kind of really actually tell people in a simplest form, but also not miss any information. And this, trust me, it is not easy to discuss like a sophisticated stereo EEG followed by possibly VNS or resection to somebody who actually has a hard time even actually understanding some concepts. And we have also involved multimodal education interventions. Once we talk to the patients, actually they meet a social worker and then kind of make sure they understand everything. And also we have an epilepsy coordinator who actually goes through all the information with the patients and kind of make sure that they're able to understand. And in the end, the people with epilepsy or a proxy has to make a decision. And it is the neurosurgeon's responsibility to inform consent, to obtain consent. And again, some of these laws differ depending on the time and place. And also, obviously, we're not talking about children here, which is, again, another population where a lot of this is relevant. So this is kind of the framework to when we think about the surgical or neuromodulatory treatment, like this is kind of the workflow. So first of all, once you decide what's the appropriate treatment based on the clinical judgment, which is discussed in the epilepsy conference. So first of all, where to identify all treatment options, knowing that not opting for these options is also actually an option for some of these patients. And list risk and benefits of each treatment and compare the risk and determine the optimal treatment. I had to have conversations with patients where they actually opted not to have any epilepsy surgery at all, despite being a good candidate. And, that was their decision. So sometimes that might be the decision they go with. And we had to have clear communication, multimodal educational intervention, and definitely make sure that we assess their understanding, and if there are any gaps, trying to fill in the gaps, and provide relevant information and correct any misconceptions, because a lot of times there might be, again, like cultural misconceptions, or just like the social media misconceptions, or something else that they don't understand. So kind of making sure that the decision is maintained. Once in a while it happens that the patient do agree, and then they might actually rescind their consent. So I think this is why, kind of closing the loop and making sure the patients understand is also important. So this is my last question. Let's see if this works. Okay. Ooh, no, okay. I don't know. Maybe I guess I messed this up because I don't see the next one. Okay, so let's see, sorry about that. Okay, maybe I had to do this one here. Okay. So, okay, yeah, sorry about that. I don't know. I thought it was working before. So let's say whose responsibility it is to, who is responsible for like a device once it's implanted. We use, DBS, VNS, RNS a lot in epilepsy. So who is responsible once it's implanted? Sorry about that. I don't know. This poll is not working. I'm not sure why. It says it's closed, which is not true. So is it the company? Is it the surgeon? Is it the neurologist? None of them, all of them, all of them. Okay. Shared responsibility. Okay. Awesome. Okay. Agreed. Shared responsibility. Okay. All right.
Sorry, but
So,
what do you mean by responsible?
like, responsible of taking care of it, making sure it's working, changing the battery, things like that.
Okay.
Yeah, so I kind of kept it vague intentionally. Sorry about that. Okay. Does anybody know what these devices are here that are in this picture? Oh, I gave you. So these are the devices that were in use a couple of years ago, but have been out of circulation. So one is this cluster headache stimulator by ATI. One was this Nuvectra's spinal cord stimulator. And then this one was actually a retinal implant to help with like vision. So what happened with these where the company actually liquidated, and then the company was bankrupt. They stopped making this product. So the patients were actually left on the lurch. They did not know how to get this working again. The battery died. They did not know how to, get it replaced, or they couldn't go for programming. I mean, I don't think we'll be there with the VNS, DBS, RNS. But, if this is a question some patients have asked me, what will happen if I can't get the battery replaced, or the company gets bankrupt and there is no support to maintain the device? So again, I don't know the answers, but these are like really the questions we're thinking about. Oh, something happened to my slides. Okay, so these is called abandonware. So when a product is no longer actively supported by the creator, and they can't be repaired, or they can't be purchased, or the batteries can't be purchased. Unfortunately, it can happen to any medical device once it's because it's a company that might go under, gets bankrupt or gets liquidated. And definitely it's really traumatic and dangerous for the patients when this happen. So again, like this, I'm not saying this is like we need to bring this up with every patient, but again, kind of just keeping this in mind, like in the future, maybe down the line, again, we don't know what will happen, but these are the questions we need to ask ourselves when we are recommending these devices to patients. So this is like abandonment when, like, let's say there is a failure to provide information about the plan for medical, technical, or financial responsibility, um, failure to fulfill reasonable responsibility for support, financial support after a clinical trial, and then also to address any kind of safety concern or deterioration of device effectiveness. So last few minutes, I'll just talk about epilepsy and workplace because I'm sure you have like new fellows and they always, if they request for any accommodations and stuff at workplace or they need any, FMLA paperwork filled, like what should we think about? So there is Americans with Disability Acts does have, a clause for epilepsy. So according to Equal Employment and Opportunity Commission, there are some reasonable accommodations. So what these are is they should have a break to take medications, or if they need to recuperate or seek some treatment after a seizure or adjust to their medication. They need a private area to rest after having a seizure, maybe like a rubber mat or a carpet if they fall. Adjustment to work schedule, which might mean, no night shift for some of the patients. Had to request that they can't work nights, or they need to have, same start time or same end time. And then kind of maybe they need a checklist if they're having memory problems, like most of our patients do, kind of assist in remembering their task. And then some patients also might have a service animal and allowing them to bring their service animal, somebody to drive to their meetings or work-related events, or permission to work from home. And again, reassign their duties if there is a vacant position. So these are the reasonable accommodations. So, okay, so we do have a few more minutes for questions. So basically, I think we come across ethical issues on a day-to-day care for epilepsy patients. We need to be aware of the principles that affect epilepsy management, and we need to have a defined framework when we are recommending epilepsy surgery workup and neuromodulation. And lastly, knowing kind of the ADA rule helps us to advocate for our patients at workplace. So, oh, this is my last thank you. So this was Dr. Navy. Remember, I had like I was pregnant during fellowship and I had baby like came earlier, was supposed to be born in December, was born in October of my second year. So it was a very stressful time. But Dr. Navy was like really supportive. So that Jefferson baby is now 8-year-old, and for some reason she's really into roller skating now and asked me to take her every weekend. So thank you. Any questions? Happy to take any questions.
Oh, wow. That's amazing. Thank you for the wonderful lecture as well as those wonderful photos. It's really, really great to see. So I'll open it up to the audience. Anyone have any questions? If not, I have some questions. So a couple of things. One, it's interesting. Well, one is a comment and then one is a question. So it's interesting. You mentioned that about the driving laws and things like that. One thing I'll mention is there was an interesting study, a multi-institutional study looking at epilepsy surgery candidates. And they confidentially asked these patients, were they driving? None of them should have been driving.
Yeah.
And it's interesting, about a third were still driving. And they also looked to see if it was different between states with mandatory reporting versus no report, physician mandated reporting and not. And there was no difference. And it was Jefferson that was, the mandatory state reporting. So it's interesting that, people, as you say, people drive anyway, whatever they're telling us. I mean, we want them to tell the truth. But sometimes they're not really telling us the truth. But one question is interesting that I enjoyed hearing about all the challenges in your unique population, and what you mentioned, that multimodal education that you provide, which is really great. at what stage do you provide that? Do you provide that in your sort of early on education or discussion of epilepsy surgery, or is it only after the person has kind of indicated some interest in epilepsy surgery?
So anybody who is, comes for like a new patient visit, we do have like a handout, we give it to them, which has like, basic information about epilepsy and things like that. But definitely once even they agree to undergo the workup, we start that process. I mean, unfortunately, our wait time is anywhere from 6 months to 8 months to get all the tests done, which is very unfortunate, but a lot of things is not in our hand. So as soon as they agree to have this testing workup done, we usually communicate with our coordinator who kind of sets this up, initially has just a phone call to kind of go over all the tests. And then we also have like a social worker visit scheduled for them. So we have like a one nurse practitioner who does this kind of once the workup is midway or almost towards the end, before we discuss in the epilepsy conference, meets with them along with the social worker and kind of goes over if they had, what questions they had. So we do kind of that assessment. And in the end, again, we have some, written information material to discuss with them. And once the epilepsy conference is done, we discuss them over the phone, and also they come in for a separate visit, which is like a longer, like an hour visit to kind of sometimes if the surgeon is able, he comes in as well, because sometimes his clinic and our clinic overlap. But if the surgeon doesn't, definitely the coordinator and me will sit and kind of discuss all the options. Um, Sometimes it needs a little bit of reinforcement. No, they will say, "Oh, I will talk to the surgeon and I'll get back to you." So it's really not that easy. Some like people, you don't agree. I was like, what? Like, was very like very like different for me coming from Jefferson here. Like they don't like, why are they not like agreeing right away? Why do they need to think about it? So it was, yeah, so it's a process. Again, like, it's not perfect, but I think with our patient population, we definitely need that reinforcement, re-education, multiple steps along the way to kind of, to achieve. In the end, they're like, yeah, I'm glad you told me to do this. I'm seizure free now. But again, kind of getting there sometimes can be a lengthy road.
Yeah, no, thank you so much. Yeah, I was just reason why I asked, I was wondering if you do it, like how early is, would it be more beneficial to have it really early and because maybe they're saying no because they don't understand it and they don't even want to go through the workup, or does it change people's minds? I mean, I don't know if you have data on that or not.
Not really. This is what we are like what we're trying to do a survey before that was just around COVID, kind of to understand, did you understand the workup or like, but it was really hard because um the IRB here had like really strict rules that any survey had to be given by somebody who was on the study. So it was really hard to get that study going, because then we'd have to give it to every person who checks in. If you want to give it to a particular patient, they wanted like the person in the study to come and give the survey. So that's why we kind of couldn't do that survey. But again, if we give to every patient who comes in, some are not might be epileptic, or some might have, might not be surgical candidates, or might be seizure free. So I think it wouldn't probably like validate the survey if we would give to every patient. So we kind of gave up on that study.
Sure. Yeah. Thanks. Yeah. Any other questions or comments from the audience? Okay. Well, thank you so much again.
Thank
It was
you.
really wonderful and really wonderful to connect with you again.
Thank you.
So next month, actually, we don't have a lecture yet, but there is a possibility there still will be a lecture. So please just be on the lookout for your email. We do have a lecture for the following month, and it should be hopefully monthly thereafter. But otherwise, enjoy the rest of your summer until we meet again. See ya.
Thank you. I hope I'll meet you in Atlanta. Okay, bye.